I think one good advice that I once got when you want to do a lot of things, which maybe many of our listeners do, is that you can do everything, but what you can't do is do everything at the same time.
Hi everyone, and welcome back to the High Impact Medicine podcast, a podcast that chats to medical doctors pursuing diverse career paths. I hope these discussions will leave you informed and inspired. I'm your host, Kujani, a medical student from Cambridge, UK, and today's guest is Dr. Otto Schell, a consultant physician from Sweden with extensive clinical experience in emergency care, internal medicine, cardiology, and critical care. He is a dedicated researcher in critical care, global health, and health systems, and has led projects in Tanzania, Malawi, Sri Lanka, and Sweden. He has leadership experience at the local, national, and international level, and is also the vice president of the Essential Emergency and Critical Care Organization, which champions the integration of fundamental life-saving care into health systems worldwide. Welcome to the podcast, Dr. Schell. I'm really looking forward to our discussion today.
Thank you so much. I'm honored and excited to be here.
Fantastic. Let's start off with something that maybe takes you back to a decade or so ago. What led you to pursue medicine as a career path?
So, like many people, I think it's the combination between science and humanities and that soft spot that can combine both. So that's what led me to medicine.
Do you have an early memory of when you realized medicine was the career path for you?
So that's not an early memory. I think I was struggling a lot what way to go. I was interested in journalism and engineering and then medicine. It tipped over because the possibility to help people, to kind of engage in problem solving with these important issues and also to do science.
To give our listeners a bit of an overview, from medical school to where you are today, broadly, what does your career path look like?
The bumpy road, because me and my wife to become, we got a child when I was in the middle of med school. So we had a couple of bumps there and we went out traveling. And that was connected to global health research when I was a medical student. And we had the chance to work with Professor Hans Rosling, who is this amazing professor in Karolinska in Sweden and communicator around how the world works. So I was quite involved in research by then, by ending med school. And there was a decision made by me to stop doing this because I was a young parent and I decided, though, if I'm going to practice what I learned in med school, I had to be a doctor. So what happened was that me and my wife and our growing family moved to a small town outside Stockholm to Nyköping and started doing our internships there. We never find a reason good enough to move back to Stockholm, by the way, since then. So I still work there as an internal medicine doctor and a cardiologist. As a resident, the opportunity came to come back to global health. And I found what was to become my brother in crime, Tim Baker. He's a UK-Swedish physician and who went to Tanzania and lived there for 2 years. And we found that we had the same experience of what happened to critically ill patients unnecessarily. And it happens in my setting in Sweden and his setting in Tanzania. And we tried to figure out things to do about it. And that's how our baby was born. What we would call EECC, or stands for Essential Emergency and Critical Care. During these years of initially research is that to make something happen, we started this network around this idea, and now we have members from over 90 countries in it, and we recently also set up an NGO, EECC Global, to be able to be not only a network but a partner that can make formal alliances with organizations.
So you had the opportunity to do some field work in Ethiopia during your medical school. I'd love to hear more about what kind of the impression this left on you and how this kind of changed your thinking, if at all. Could you tell us more about that?
So I think, first of all, it was an experience what the world could look like, which was so far from, this was the poorest part of Ethiopia, with 1 or 4 kids did not survive the first 5 years. And what we saw looking at the feeding patterns or what food was given to children was that there were so many evident sub-optimization in what happened. So the weaning practices were quite dangerous in some places. And there were also huge differences between the villages that from the outside looked similar. But in some villages, children get a very varied or as varied as possible food, whereas in other villages they were kept to 2 nutrients until they were big. And this, of course, could have a big impact, and it seemed not impossible to do big changes.
And so I imagine kind of ambition to make a change was probably sort of brewing in the back of your mind, even as you were doing your internships back in Sweden. From that point on, how did you go about establishing these connections within the global healthcare field? You mentioned Tim Baker, that was quite influential. How did these connections and eventually EECC come into fruition?
This is a long journey, starting with this and seeing the evidence that this is so common. The idea is basically that the most basic and simple care of critical illness is not providing to these patients who need this care urgently, and that causes a lot of unnecessary deaths. So that's the main idea of our work, to address this huge gap. And it was, so we tried to work with research to find the evidence, so that because this was overlooked. There were so many misconceptions around critical care, which I will come back to later. Eventually, there was something called COVID-19, and suddenly critical care became well known, and funders that we have approached before and tried to collaborate with, but fallen at the last step, like the Wellcome Trust. They came back to us and wanted us to go with this idea, EECC, in COVID. And since then, we've established good collaborations with UNICEF, with the World Bank, and with the WHO.
After you came back to Sweden, it was when you were sort of doing your kind of registrar level training, or kind of your specialty training, that was when you started finding the opportunity and maybe more of the time to get back involved in this sort of work. Tell me a little bit about the EECC, so the Essential Emergency and Critical Care Network, and what it stands for and the concept.
Basically, we're talking about a huge opportunity to saving many lives at low costs in the health sector. So what EECC tries to do is to change the way that critical care is understood and provided. And as you who listen, who are medics, you know, the critically ill patients, they're the one with vital organ failure and a high risk of dying in absence of urgent and adequate care. And they may have any different underlying diagnosis, yet so many people die unnecessarily without receiving this most basic care or critical care. So we'll try to find out that this needs a name to be able to talk about it. There are many initiatives, like from Florence Nightingale and to early warning scores, but a name is needed, and EECC is this care that is as low cost and simple, life-saving actions so it can be provided in any ward in the world and relevant for large patient groups. To be concrete, it's using vital signs to identify who is critically ill, where patients are taken care of, and act on this information, which is equally important. Otherwise, nothing happens. So you need to stabilize the patient by securing that the airway is open, they are getting oxygen or fluids. So EECC was initially an idea which we published 7 years ago, like a concept. In the pandemic, we reached a global consensus of its content, like a version 1.0. So now EECC comprises of 40 clinical actions, and like identification of critical illness using vital signs, providing this stabilizing care such as oxygens, but also processes to facilitate this care, clear communication, and having strategies for patient get this care early without paying first.
Before you came to this kind of research field, what sort of work had been done in this area? Had much been thought about, or was this pretty novel at the time?
So the question is yes and no, because nothing is novel with EECC when it comes to the care to do. It's what's in all textbook. And the problem is that the care was often not provided, and still is very often not provided.
That overview of what EECC is really helpful, and it sounds like it's kind of addressing a problem such that we have patients who are critically ill where their vital signs are deranged, but these patients aren't adequately picked up and not treated appropriately. And this is essentially the crux of the problem that you're trying to address. You're trying to pick up these patients that should receive relatively simple, low-cost, life-saving treatments, but for some reason they're not. And this is the gap that EECC is trying to address. So take me through maybe a project that you've worked on in one of the places you've worked. What is the type of work and the implementation that EECC would do?
You have a young girl, 6 years old, coming in with malaria to a hospital in Africa, often diagnosed with very well, because the diagnosis care is much better than the care of critical illness. She's weak. She's getting the right anti-malaria. She's admitted to the ward. But she becomes unconscious in the night, and she's still on her back, flat on her back, and she loses her airways, and that's why she goes. To address this, you have to fight kind of quite large system. Having a system in place to identify critical illness and act on it when it's not in place. We all know that changing our behaviors, whatever it comes to training or anything, is difficult. And in systems, it's also difficult. So there are many advocates for the diagnosis care in healthcare. The leaders following these strong movements to say we need better surgery, we need better malaria care, we need implementing things that are essentially good. The problem is that care of critical ill is lagging behind. Additionally, those who engage in care of critical illness, critical care physicians, this specialty is, like other medical specialties, mostly interested in the front line. I mean, how to run a mechanical ventilator, it's a fantastic thing, but the patients who don't reach an ICU, which are, for example, in many parts of the world, very rare and varies a lot between countries, many folds, they don't get the critical care physician. They don't meet each other. So that's where the big system problem lies. And an additional question could be then, why does this happen? I think there are three major misconceptions when it comes to understanding of critically ill patients. And one of them is that it's not common. Because if you only look in the ICUs, you only see the few patients who are there, which is a small number. But actually, we found that 1 in 8 patients is critically ill, and a fifth of them die before they go home. And the other conception is that the critically ill are in the ICU or maybe in the emergency unit. But actually, we see when we look at this systematically that the large majority is found in the general wards. And the third thing is when critical care is mentioned, especially when you come to global health, it's assumed to be high cost. And the association goes directly to the ICUs again, whereas there is this low cost and highly cost effective care like ECC, which only cost $14 to save one life. So through these three misconceptions, that's what we try to do in the work we're doing to help the system to make the right and clever priorities.
And that's sort of what your kind of research more recently that's been published in the Lancet, the recent paper on your study, African critical illness outcomes. And also you've done a study in Malawi, Sri Lanka and Sweden comparing these countries. And in all of them, you find that actually patients that are critically ill aren't just found in the ICU. There's this underserved population on general wards that tend to be understaffed, that are therefore experiencing outcomes that are suboptimal because of lower awareness and systems level change. And it's quite a big concept. What are the different components of that? How do we do that in very simple terms?
So the idea of EECC Global and the movement that we try to gain interest in and to see this potential is that no one should die of a reason that EECC can stop. It's unnecessary. It's so cheap, and we can do this in all healthcare settings. Changing the system. So, I mean, EECC is not rocket science. Whereas making this happen is definitely rocket science, obviously. So there are many components and a lot of, it's not the same everywhere, but if you don't have the leaders on board to see this as a priority, it will never happen. You also need a buy-in from the healthcare workers. But to change priorities, there are so many interests fighting about resources like staff time and like money. So also at the political level, this is needed to come through. I mean, it's such a strong argument, so I'm very hopeful, and I see that change is possible. For example, one good example which was fantastic and is underway, is that oxygen, which is a vital ECC thing in the COVID pandemic. We actually got this momentum for oxygen finally. We had almost 1 million children dying each year from pneumonia. And colleagues have made studies in Malawi seeing that only one of 9 child dying with pneumonia in Malawi received oxygen. for example. That's appalling numbers, but it's not known by the global health community. So it hasn't been seen. Instead, coming back to these misconceptions in the start of the pandemic, what the rich world did to help less fortunate countries was often to send ventilators, which are much less cost effective and often drain resources, and most of them were not used, we've seen. Because because they were sent to places where there was not a reliable oxygen system. But what happened is that at last, EECC action, oxygen has been put on high on the global agenda. So that's a very positive example that change is possible. And we say to benefit these from oxygen, we need to go along with all the EECC, the other low-cost life-saving actions in EECC.
That's a pretty nice example of something so low cost and simple that has just been completely overlooked in a certain group of patients until COVID came along and we started thinking much more about where it could be applied beyond one particular ICU setting. Do you have any other examples of EECC kind of actions? So oxygen's one of them. Any other examples that listeners can get their head around the types of things that we're trying to make a priority?
So I think, one very basic is the use of vital signs, which has come and gone. It's become popular again in Europe, which is good because they are very low-cost things that could be used. So to get them in place, to have a good idea of what happens to the patient, that's a key thing within ECC, to identify the critically ill patients. But I think it's also very important to see that we've seen with vital signs that they do nothing unless they change care. And for example, what we found in Tanzania in some early work, that was in an ICU who were very good at taking vital signs, but there was in that ICU there were very few doctors in a large hospital, but quite a few nurses, but they had no mandate to act. So in more than 19 times of 20, when a patient was hypoxic, nothing changed. Or when a patient was in shock, there was no fluids provided. So the other link is to act on these vital signs. And that kind of interventions could be very powerful.
It's like we have all this data, but it's important that we use it in a clinically informative way. And to change, patient outcomes and health. Yeah. Another thing I wanted to ask is you've been working clinically as well alongside your work with EECC, is that correct? I think a lot of doctors that I've spoken to often find it difficult to find the balance between pursuing these kind of research interests or these entrepreneurship kind of ambitions, or whether it's like biotechnology alongside their clinical work, which can also be quite demanding. How have you found this, and do you maintain both because you're able to apply some of the things that you're working on to your patients?
So first of all, I want to acknowledge the challenge, because it is a challenge to split wide, and I'm if you're interested in many things, you have to believe in those researchers saying that generalism is something that the world have more use for than we have too many specialists and too few generalists. I'm happy with that, but it doesn't help with the work-life balance and balancing different interests. I have been lucky personally, good research grants who has enabled to give me some time to do this. It has not only been on spare time, so I've had time to at least do the research, which was quite good with these grants. And I had an employer who had accepted this as part of the world. Actually, our region, which is a province in Sweden, did an explicit policy to promote research, because research in university hospitals do often go to specialized. So it goes very well with that. However, I think one good advice that I once got when you want to do a lot of things, which maybe many of our listeners do, is that you can do everything, but what you can't do is do everything at the same time. That way, what I did, I made the choice to not accelerate my medical career in any ways. So my clinical career went slower because I just didn't do all the mandatory moments, and I took time off. And also research career, I made my PhD over 8 years instead of the standard 4. And that was that was a fortunate way to do it. I mean, not for the paycheck, but for life.
It's really interesting. So did you do your PhD after quite a while after medical school then?
I did a PhD part-time from when I was 40. But it also so that research doesn't require, at least formally, to be a PhD student. So I restarted research before I was admitted as a PhD. I haven't reflected on it. I have been not so focused on the formal merit order. It has come eventually.
And day to day now, what does your work look like? The average day in your life working
Maybe say
ECC?
average week because they are different. So I have 1 or 2 research days every week for the moment. It's been more before, but now it's like that. So clinically, I'm a senior consultant. So either I'm in the ward, or I'm having eye patients, or I'm the cardiologist consultant doing some echocardiography, and then I have night shifts as a consultant. In research, so what we tried, the biggest project right now is a big implementation of EECC in Tanzania with the technical assistant partners here in the Muhimbili University. And it's the Minister of Health who will introduce EECC in 6 regions, which is quite big. In all small hospitals and facilities, not the biggest one, because there are different organizations. They are equally needed there, but that's the project, trying to get this large scale implementation as good as it possibly can, and also to follow what happened with research. That's the biggest project ongoing.
Wow, so it sounds like it must be quite a busy time for you then. One thing I wanted to ask before as well, when you mentioned kind of the implementation, you're working with big organizations to sort of bring EECC to hospitals, is that right? Like UNICEF, and you're the acting kind of organization. Who is involved on the ground for these sorts of things? Who are the people that you have to communicate with and kind of liaise with in your job?
It's decision makers. I mean, the project in Tanzania, which is actual as an example, it's really what we really try to do, learning from mistakes in implementations before in history, is to engage with each level. And if you don't have the high level stakeholders on board, we never get there. One nice thing with Tanzania is that the Minister of Health nationally has adopted ECC as a strategic aim for all their healthcare. So that's a box to tick. I mean, it's a piece of paper, but still, that is very good. And after that, we have had big workshops with high-level stakeholders, and now we are about to engage with the local leaders of hospitals with workshops, and with the health workers with training. And then we try to provide job aids and supervision, so there can be audit and feedback, and sharing this local knowledge in the facilities to see whether ECC is happening or not, because essentially that information is missing in most places in the world. In most places in the world, ECC is no one's baby. It's the specialists in the clinic are focused on their specialty, and the critical care physicians are not seeing these patients. That's the gap we need to address.
It sounds like the kind of the first phase of your work was generating this data to show that there are these big misconceptions in the way that critical care is delivered, and it's through your papers in the Lancet in Africa, in Malawi, Sri Lanka, that have given enough robust data to then drive the change, and for local stakeholders and decision makers to then adopt EECC. Is that right?
So that's in a theory of change in the hindsight. That's very well described, and that's we found when we saw that it wasn't. I can really remember the place I was in when I realized that when we were looking at how common is this, we see these patients dying in the wards and in the emergency units because the basics are not done for critically ill patients, and how common is this? And going through the literature and see there's nothing here. We had an idea of how many critically ill patients there are in the world, widely cited, and good work by Adhikari and colleagues. It was based on an extrapolation from American ICUs to the rest of the world. So we decided we need to go for this data ourselves, and it's been a long journey to do that. It has been necessary to get the buy-in that we have now.
Now that you can then implementing it, you're going to need to audit and evaluate. That's sort of what you're currently working on, is that right? Well, the in Tanzania, the implementation, evaluation, auditing, that sort of work. It was interesting reading some of your papers. One thing that struck me was you've worked across multiple countries, so Tanzania, Malawi, Sri Lanka. You had some data on the United Kingdom, and actually there isn't a huge variation. It surprised me how high there are critical care patients that weren't on ICU were even in what I would perceive a very well-resourced country such as the United Kingdom. And I just want you to, if you could tell me a bit about why, even with such large variations in resources, you've mentioned it briefly, but what are some of the biggest differences and similarities across critical care delivery between the countries that you've worked and researched in?
So I think this is very interesting. I think one thing to understand why these numbers are so similar between Malawi and Sweden, for example, with the prevalence of critical illness and the mortality is that, and where they are located, is that the Swedish patients are 75 years old in average or in median, whereas in Malawi it's 41. So it's a completely different set of hospital. And we only looked at adults in this study, by the way. EECC is equally important for children, but this study was only in adults. Resources. We do so much more in healthcare in the rich countries than is possible to do with low resources, so that we have survival up to 75 years old and a life expectancy of above 80. And that comes with a lot of medicine, so a lot of medical investments in surgeries and other things, as well as, of course, the big prevention thing with vaccines and nutrition and all that. But for the health sector, the costs are much higher in high resource settings. But still, we have this problem that we miss the basic care, and that's a similar problem because there is no advocate for this. So what's new and fancy that's promoted by the industry, that is liked by the medical profession, like us, we're really interested in a new fancy treatment rather than the basics that everybody knows. Toxic patients that with oxygen. I don't want it. That's not interesting. And for politicians who need the votes, it's very nice to show that we have a new machine or a new surgery or a new ventilator or a new cancer treatment, rather than saying that we should do basic life-saving care. But I am an optimist. I mean, this is a huge challenge. I think it's human nature. If also think that impact, saving many lives is a strong argument. I think it's even sexy if we use that.
Do you feel like through your work, you're able to gain fulfillment by thinking about the impact? Is that what you find fulfilling day to day and what drives the work you do? Kind of, where do you find your motivations for this type of work?
I think impact is overarching, and that is kind of what can make me go on. I've decided, like many colleagues not in global health, to keep working clinically. And I think also meeting real patients is an important driver, and also sense checking of what I'm doing. That it's meaningful and useful.
See, yeah, that's a nice way of putting it. What would you say are the challenging aspects of kind of setting up kind of a network like this, and what have been some of the challenges for you?
It's been so much work. And it's interesting because you can have so many good ideas, but for something to happen, you really have to put in the work. The idea we're trying and have been quite successful is to become more of us who work in the same direction. When it comes to manpower, we're also trying to mobilize resources now. We need funding to do this work, to be more professionalized and have more hands to help this vision to happen.
Where do you see EEC kind of, how would you see it expanding and changing next 5-10 years?
So what we hope, going back to the vision, which never will be, but the aim that we shouldn't have patients dying from not getting the most essential care of critical illness. Then I think that the major work streams to work is awareness rising, because people don't know this is a thing, this is needed. We need to help health facilities to implement this. We need to make that happen, otherwise it won't come to the patient. And we also need to get additional research, because it's rocket science how to get it implemented, like most changes in healthcare, but especially one where you don't have a strong industry to help implementation. And it will also benefit for even more robust data of cost effectiveness and budget impacts to help governments to make these decisions on the direction. But I think awareness raising is probably the most important one, but still most people believe that the critically ill patients are in the ICU and that they are getting what's needed if you're critically ill is in mechanical ventilators patients because they don't get oxygen and fluids and are not identified.
There's so much power in the simple things, and when we get the simple things right, everything else is just a bonus. I want to know, what type of medic or what type of person do you think would fit a role like the one that you're doing? What sort of skills do you think you've had to develop, or you think you've had to make you successful in this?
I think it's difficult to say. It can be different kind of persons doing this, but obviously it has helped me to move between setting that I like to meet and chat and laugh with people in different setting, and I'm quite curious. I like to come to see in new settings and try to understand what works there. And I've been inspired by Hans Rosling and, for example, to not veer off from thinking big, which is very dangerous because if you think big, you can do big errors as well. But I think that's good. But it's not necessary as long as you're a team. You can provide in different ways.
And kind of related to that there, what's one piece of advice you might have to young doctors or medical students interested in global healthcare and maybe making change like you have in critical care? What would your advice be?
So my advice, but I'm biased. I think you should focus on two things. One is the impact, the potential impact of what you're engaging in, and the other thing, which is equally important, is what you like to do. You should do things that you like to do. Otherwise, it won't be a good thing for you or for what you try to do.
Sure, of course.
Another advice is to be on site. Don't believe that you understand how another system, how the world works. You need to be in place. You need to observe, talk, ask questions, and for some time as well. And there is almost a rationale behind any behavior. And that you don't obviously see, and you have to be humble in that not if you have a sick child and you're referred from a primary care facility with a sick child, we see in many poor countries that the child don't get there. But when you interview the mothers or the father, the caretaker, there is this is a danger for the child, but there are so strong arguments going home and not risking the rest of the family for economic reasons, for safety reasons, and there is always a rationale. Sometimes that rationale can be changed by new information, new systems, and so on. But you have to be humble there.
We need to sort of understand why things are the way they are before we start changing them. Was there any kind of book or anything you read or listened to that was particularly influential for you that you'd recommend?
So I'd really recommend How I Learned to Understand the World by Hans Rosling, who unfortunately passed away too early. But he's this global health professor, spent a lot of time in different places in Africa, actually characterized a new disease. But that's not the most important thing. The important thing that he is a brilliant communicator. He's brilliant at thinking large and fitting the large patterns into the life of real people, and the other way round. So that book is great. Hans Rosling is also the founder of the Gapminder Foundation, which have kind of in data, which is, they have a fantastic website if you haven't seen that I really recommend to see the world and what kind of different income level matters and what misconceptions there are.
Sure. Thank you for all those recommendations. I'll have all the things you mentioned today linked in the show notes as well for the listeners. Thank you, Dr. Schell. We've taken a kind of tour of your career from medical school, doing field work in Ethiopia, and diving back into research later on in your career and thinking about some of the basic things that we should get right by delivering low cost, effective, and needed critical care to patients beyond just those in the ICU. We can have quite large impacts on patient outcomes. And it's really interesting to see how you've worked so hard to develop all the data required for the EECC. And now you're in the process of implementing this. And that's a really exciting phase, I think, of your work. And I hope that all goes really well and you're able to find a lot of fulfillment in it. But most of all, I'm really grateful for you for chatting with me today and for your time. And I'm really hoping our listeners can take away as much as I did today. So thank you so much, Dr. Schell, for featuring on our podcast.
Thank you very much for having me.